TopMedTalk.
Well, hello and welcome to TopMedTalk. We are in Denver, Colorado for the Society of Obstetrical Anesthesia and Perinatology, or SOAP. I'm Desiree Chappell, co-editor-in-chief of TopMedTalk and your host today. And joining me is the founder and former editor-in-chief of TopMedTalk, Monty Mythen. We've allowed you to come back.
Thank you, Desiree. As we've said on lots of podcasts recently, last August I joined Edwards Life Sciences, so we decided that I should fall on my sword and retire from many positions.
Yeah, I was going to say.
Many positions, including being editor-in-chief of TopMedTalk. But both Edwards Life Sciences and y'all have kindly let me sit in every now and again, but it seemed appropriate.
It is, and we've had a lot of fun, lots of great conversations. This is the first time we've been to SOAP, isn't it?
It is the first time we've been. It's the first time I've been to SOAP.
Yeah, me too.
It was, unusual for me to say the first time to go to a meeting, but this is wonderful. I've known about
your many years.
I've heard about it for a very long time.
Yeah.
Because lots of my academic colleagues were distinguished obstetric practitioners who would come and speak here. So I'm very familiar with it, and it's a cool name.
Yeah, it is. It's totally cool
name.
Now
We're here, and it's a great meeting.
It is a great
lovely
meeting.
Bunch.
Yeah, so at TopMedTalk, some of our first interviews at our first big production at ASA in 2018, the American Society of Anesthesiologists in San Francisco, with some really great conversations with presidents and former presidents of the SOAP organization. And they were fantastic. I think some of them are they're still walking around. I think we're going to be able to catch up with some of them today. So that's exciting. Well, Monty, we couldn't do TopMed. Oh, were you going to say something?
No, I was going to get to reflections on yesterday. Go for it. We couldn't do it without our sponsors.
We couldn't do it without our sponsors, could we? And SOAP has graciously given us this booth here in their exhibit hall and partnered with us. So thank you very much to SOAP and your organization and all of our other platinum sponsors, Edwards Life Sciences, GE Healthcare, Medtronic, have all been there for us to keep TopMedTalk free and open access to the world.
That's the key to it.
Yeah.
We don't get paid. Some other people that help us get paid, but we can only make it free open access to the whole world, which was what the mission was with their sponsorship. So thank you very much.
Yes, thank you. Well, Monty, reflections on yesterday.
Because I was listening again to the podcast that's about to go out that was recorded yesterday with one of your ex-colleagues who lives locally. You can touch on her in a moment with learning more about TIC.
Yes.
Both
of us, we weren't for sure what that was.
We didn't know what it was. There was a full session on it yesterday, and we had to say, well, what's TIC? And it is trauma-informed care. Yeah, so please do listen to that podcast because it's really, really important issue about patients who come in who've got past trauma, that they should really be part of your history to determine, is there any traumatic episode that you've had that we should be mindful of in your care? Yeah. And that particular example was about C-section and abuse, particularly that case was cited was about rape, and the fact that we should be part of the standard. We ask about allergy, right? Why don't we ask a bit more about that? Yeah, absolutely. So that's a big lesson for me. Yeah, and definitely I encourage everyone to take a listen to that, and hopefully we're going to get a chance to catch up with Dr. Tracy Vogel, who gave that presentation yesterday. So informed care, we should all learn what it means. Learn more about that, absolutely. Well, Monty, in true TopMedTalk tradition, we are here in the exhibit hall sitting down with attendees, presenters, friends of the TopMedTalk family to share the highlights and all the good work that's being done in this particular space, obstetrics and gynecology. So our next guest is Dr. Barbara Orlando. She is Associate Professor, Division Chief of Obstetric Anesthesiology for UT Health in Houston. Dr. Orlando, thank you so much for joining us.
You're welcome. Thank you for having me.
Yeah, that's fantastic. Do you mind if I call you Barbara?
No, please do.
Thank you very much.
Now, before you get going, Des,
yes.
Because I've been lucky enough to meet Dr. Orlando a couple of times in passing, only briefly, but I already make the diagnosis that you are kindred spirits.
He did. He told me that. And so he said, you will absolutely love her. Yes. So I've been anticipating this conversation. I'm a big fan. I've been hearing about all the wonderful things you've been doing.
Thank you. I appreciate that.
Barbara, why don't you tell us a little bit more about yourself, your practice?
I work at the Texas Medical Center in Houston. It's a huge town within town. It's a big group of hospitals. And I have been recently hired to take over the Obstetric Anesthesia Division at Texas Medical Center. So Memorial Hermann, and I cover also LBJ, which is the second site. It's been 3 years now. My predecessor, Dr. Suresh, who is very well known, so started building this division, and I continued building it. And making it a division that is very in line with all the guidelines from SOAP. We have a SOAP Center of Excellence. We got accredited in 2022, which is a big award or accreditation for a division, because that means that we are doing everything by the book and how it's supposed to be done with guidelines, recommendations, staffing, equipment. So it was a big acknowledgement for us, especially because we are a young division. Dr. Suresh started building it 2 years before me, so it has a 5 years life.
Yes.
And it's been an amazing experience. I was coming from New York, where I did my residency, my second residency, my fellowship, and I worked as an attending. And then I got this opportunity to come to Houston and be in charge of that division. And it's been an amazing journey, really.
I was going to say, you don't sound like you're from Houston, Texas for sure.
I don't.
Or New York.
Really? My accent is very New Yorker.
Right, very much so. Yeah, it is very diverse there. But
I come from France. Well, I was born in the South. I did my residency in Paris. I worked there as an attending for a year. And my husband was sent here in New York, was sent to New York for his work. And we were supposed to stay 2 years, and we stayed 21 years.
Oh, yeah, that's the way it usually works, isn't it?
Yes. So after 8 years of non-working, I had to go back to doing my residency because I love medicine, and that's my passion. So
that's fantastic.
Yeah.
Well, before we kind of dig in, one question that I had, the division there in Houston, about how many deliveries is that for you?
So delivery between LBJ and the Memorial Hermann is about 7,000 to 8,000 delivery a year.
Yes.
The bulk of it is at the Memorial Hermann Center. It's about between 5,500 and 6,000, maybe a little more. Recently, we've had an increase in workflow with some new groups who have joined, OB groups.
Mm-hmm.
And it's two very different sites with very different patient population. We have the very high risk at the Texas Medical Center, and LBJ is more the healthier patient. It's a community hospital.
Mm-hmm.
So it's a very different patient population. And it's very interesting to have both sides.
And do you have a NICU at both then?
Yes.
NICU, okay.
Yes.
Thank you.
We are a level 4 maternity at Memorial Hermann. And I believe that LBJ is a level 4 as well. One of the main difference between level 3 and level 4 is to have OB anesthesiologists on site. Level 3, they recommend anesthesia, but level 4, they specifically recommend OB anesthesia trained people because it's a step up in terms of the comorbidities that the patient have.
Yes, for sure.
And just a little bit more, because we should recognise that not everyone knows NICU. I said NICU.
You did say NICU.
The neonatal intensive care unit, so the babies who need extra help in what looks like an intensive care unit. And sometimes they're very tiny, aren't they? They fit in the palm of your hand.
They can be very small. Now what we call the viability went down to 23 weeks. So they can be very, very small.
And the mums need extra help? The critical care for the mums?
ICU, yeah. That's also part of the criteria for level 4, level 3, is to have an ICU that can take care of mom, maternal ICU. I mean, not necessarily for the mom, but an ICU that can take mom in charge.
Yes. Thank you.
Right. Yeah, I was curious about that as well. So, Marla, tell us about your work here in SOAP. There's an app that you're developing?
Yeah, we've been working with one of my colleagues from Stanford, Dr. Ortner. We've been working on an app to kind of centralize algorithm of common bad outcome we can have, such as amniotic fluid embolism, eclampsia, ACLS, specially designed for mom. So we've been collecting those algorithms within the education committee, SOAP education committee, which I belong to. So we created that task force for the SOAP app, and we have some SOAP members who have been volunteering to create algorithm for the app. And it's going to be announced, I think, at the opening ceremony. There's a new partner. It's a platform that allows to display all those infographics and algorithms. I think it's called C8 Health.
Mm-hmm.
And when you have that app on your phone, you can open it and then you can access directly all those algorithms that people have created.
Yes.
For SOAP members and non-SOAP members.
Great.
It's good because a lot of places where you have OB patient, you don't necessarily have OB anesthesiologists.
Right.
You can have anesthesiologists to do OB.
Mm-hmm.
And I think it's a good support system for them to look at it, because those are complications that are not necessarily very common. So if you don't do it all the time, you kind of not sure what's the most updated data on it. So those algorithms are going to be updated regularly and gives you the current literature, recommendation, and guidelines.
Oh, that's fantastic. So it's a very high level, and then you can go deeper if you want to read the study and things like that. All of it. Right. That is a fantastic resource. It's kind of like the easy button of OB anesthesia.
Correct. and I got the idea of that when I saw the PD crisis app, which is very similar to it. So it's for PD anesthesia, and they have all kind of algorithm. It's a little more interactive than ours because it can actually calculate the medication by weight, especially for a little baby. So you input the weight of the baby, and so it's really cool.
Yeah.
And when I saw that, I was like, we should have that for OB.
Yeah.
And here we go.
Here we are.
It's been a long journey. It's been about 6 years in the making.
Yeah. Yeah. Those things are, on the face of it, looks like it would be it's so relatively easy. But it's very complicated.
And I really wanted to make it with the stamp of SOAP. I didn't want it to be just an app, because we could have created an OB anesthesia app, but I wanted SOAP to endorse it because I think it's important.
Absolutely. Absolutely. Well, so Barbara, I want to hear about some of the work that you're doing, because I've heard some of the projects that are going on along the lines of some of the newer technology coming out or that's been out in different spaces, but how we're now putting it into the obstetrical space. Can you tell us a little bit more about that?
So when I arrived 3 years ago, I saw those devices in the room, and I never had seen them before, and I was interested, and Dominic was the rep at the time.
Which device?
Yeah, say which one.
So it was the ClearSight and Hemisphere, and it was the finger cuff for non-invasive blood pressure continuous monitoring. And I was very surprised and interested to look at it. So Dominic was the rep at the time, and he showed me how it works. He explained me what the benefit from it was. And as I went deeper and deeper into the different options that the device was offering, I was like, wow, this is really, really cool for a pregnant patient. They are the perfect patient population to use those devices on because they're awake. Mm-hmm. You don't necessarily want to put Artline on them. I mean, they're coming for a happy ending, and you're going to tell them, I'm going to put an Artline and maybe a central line, and I need this, and I need this. And they're awake. They don't want anything to be different from the other patient. So those devices, to me, were really something that was fitting perfectly the OB population. Mm-hmm. So I started using it more and more, and we designed 2 studies with it that we're in the midst of doing. Hopefully we can finish them sooner than later, because I think that, and I kind of also included our OB colleagues who are very interested in all the advanced monitoring, the cardiac output, cardiac index, stroke volume, all those things that you can only get either with a echo or with a Swan-Ganz. Both of them are pretty impractical in the OB population. Yeah. I mean, having an echo requires first someone who knows how to do it well. And the body habitus of a pregnant patient is not very much compatible with an echo. It's kind of difficult, especially third trimester, finding the xiphoid and pushing on the belly is not the easiest. And a Swan is obviously not something that you would put routinely because...
Yeah. Not practical.
I think we would not agree to it.
Yeah.
So I found that option was really incredibly interesting. Yeah. And using it, I've noticed from my personal experience an improvement in the incidence of nausea, vomiting, tighter blood pressure control, less me being aggravated because the patient is shivering after we put the spinal and I can cycle the blood pressure for like 6 minutes because she's shaking and I can't get anything to work. So I think it has a lot of potential. And recently, ASA came up with quality metrics for C-section where they recommend, so we used to recommend about 3 to 5 minutes cycling the blood pressure, and now they recommend 1 to 2 minutes. So that device would fit perfectly for that because you don't want to cycle the blood pressure.
I was just going to say, it's misery.
They're already complaining when you do it every 5 minutes. They're like, can you get that thing out of me? It's bothering me and it squeezed my arm really tight. So I think it's really a great device.
Yeah.
So just have to ask, because I'm going to get, when we put this out, I'm going to get messages from my friends and family. How would putting the blood pressure cuff from the arm onto the finger stop you feeling sick? Because I say, oh, can you get one for me? Michael, the next time I go on a ferry, I want one of the finger squeezers so I don't feel sick.
So the reason why we monitor blood pressure after spinal is because the spinal is inducing a sympathectomy. It's a very well-known side effect. So all your blood vessels in the body are going to vasodilate and your blood pressure is going to drop. So it has multiple impact, not only on the mom, but also on the baby. Mm-hmm. The uterine blood perfusion depends tightly on the blood pressure and the cardiac output. For the baby, it has an incidence because they get perfused by the placenta. So if the placenta doesn't get enough blood flow, then the baby doesn't get enough blood flow. So it can have consequences on the baby. And then on the mom, when the blood pressure drops, they can get nauseous, they can vomit pretty heavily.
Yes.
They get the obstetrician gets aggravated because the patient is vomiting and they're trying to operate on the belly and the bowel comes out and all those things.
Yes.
And they get shivering from the spinal because when you cause that vasodilation, there's a redistribution of your temperature control. So they kind of like get that shivering to kind of counteract that loss of that temperature exchange with the outside. So that has an impact. The shivering has a huge impact on how well you can monitor your blood pressure because a lot of time they can shiver pretty intensely.
Yeah.
And the blood pressure is going to keep cycling and you can have a blood pressure for like 5-6 minutes after you do your spinal.
Yeah. And I mean, from my own personal experience in the OR all the time, is that if you're moving your arm at all, the blood pressure cuff, it just cycles and cycles. And as an awake patient, I mean, you're usually that first blood pressure you're trying to get. I always say, please do, nobody touch the arm. Please don't move your arm. If you do, it's just going to squeeze up tighter, which is, again, another patient dissatisfier because move a little bit, then it squeezes even tighter and then tighter. And it just is a miserable experience having gone through all of that myself.
Right.
And so I think that the other point is that if it cycles continuously, you're missing a lot of blood pressures, aren't you?
Absolutely.
Yeah.
Not too long ago, I did not use the clear side, because the hemisphere, because it wasn't in the room. And I could not get a blood pressure for 6 minutes. And I got so anxious, I kept asking the OB, can you please recheck the baby's heart rate?
Yeah.
Even though we were on phenylephrine infusion, we had all the things that we normally do. Yeah. We did a little bit of left uterine displacement. But the mom was starting to feel nauseous. And I was like, I know the blood pressure is down. But I was treating her based on my gut feeling, but I couldn't get blood
factors. But yeah.
So it's very frustrating because you should be able to monitor the blood pressure decently.
Yeah.
But sometimes the mom is shivering too much. And it's not like when you have an asleep patient and you can hold the arm. And here, she's awake. You're going to say, I'm going to hold your arm really tight. And she's going to be like, okay, that's a little tight here, because you really need to make them not shiver anymore so your blood pressure can cycle.
So I haven't done OB for a long time, but it used to be when you're in there putting epidurals in, etc. You'd be watching the mum's face very closely when you felt relaxed enough to do that, and you get that sort of pallor would come over it and that look of I'm just about to throw up,
impending. Yeah.
And then you would fix the blood pressure and hopefully things would come good. But that's all reactive.
Right. Now we can do preventive,
okay,
because we also have the hypotension predictability index value that gives us an idea. It tells us that basically within the next minute, the blood pressure is going to drop. So you can treat preventively before the mom is even going to be nauseous because you know her blood pressure is going to drop.
And is that working in the mums? Because we've always had a question.
It's working beautifully with the mom.
Yeah.
Beautiful.
Oh, that's good to know. Yeah, because I know in OB, things move even more rapidly than they do sometimes in the OR. And so I was wondering what the value of the HPI marker would be, but it sounds like that is even
very well correlated to the mom.
So are you waiting for HPI to get to 85, or is it as soon as you start seeing an increase?
When I see it up, I start treating.
Yeah.
I don't wait. So, and it's interesting because all the moms are different.
Yeah.
We start with a phenylephrine infusion rate that is kind of standard for everybody. But then you see that from one patient to another, your requirement is very different.
Yeah.
And you don't know ahead of time if they're going to need twice the initial dose or less than that. And then you have patients who come with preeclampsia, so their blood pressure is high to begin with.
Right.
So you don't want to overshoot it, but you don't want to not maintain their blood pressure enough because those are really...
Yeah. And they tend to drop out on you so quickly.
Right. So some of them can drop out because they're on magnesium, they're on multiple blood pressure medication, they're on fluid restriction. And then you come and you do your spinal and you say, here you go, I'm going to hammer you a little more. Yeah. Even though they are very vasoconstricted, so studies show that they tend to actually tolerate spinal better than non-preeclamptic. Still, some of them drop tremendously.
Yeah.
And we don't know why, and we don't know which one are going to drop.
Yeah.
So if you have that device that helps you monitor them bit by bit, bit to bit, it's really incredibly useful.
The other thing is on a traditional blood pressure cuff on the arm, if you start to have hypotension, then it continues to cycle again, and you're waiting and waiting and waiting. So there are multiple reasons why having that arm cuff, especially in this patient population, is not optimal, and I can see how having the finger cuffs would be, fantastic.
That, and not only to mention that a lot of the patients we have a very morbidly obese patient.
Yes.
So our patient population has a body habitus that is with BMI of 40, 50, 60, 70. So the blood pressure curve does not fit.
Mm-hmm. No,
it's like I call that
like it.
The one size fits nobody.
Yeah,
it literally fits nobody.
Yeah.
The curve is really long.
Yes.
So and it's larger, but for it to be able to give you an appropriate blood pressure, it has to be long enough.
Yeah.
So usually when you put it on the arm, it fits from here and then it covers the elbow.
Yeah.
So
it's not.
It gives you nothing.
Yeah.
You get like blood pressure of 180 over 120, and you're like,
yeah,
what am I doing with that?
Yeah.
I don't know, because that's probably not the blood pressure.
Yeah.
And then the factor is that after the baby is out, they want to hug the baby, they want to bed.
Yes. Oh, yes.
And they have that stuff that's bothering them, and and they're like, can you take it off? And I'm like, no.
I know. And then they start, closing, and they're still working on the uterus and some of that can cause hypotension and illness and not feeling good.
That can cause them to be sick
again.
For sure.
So, well, tell us, we're going to have to wrap up soon. What are some of the outcomes that you are going to be looking at and tracking? So
we're going to look at, we have one study is just an observation study. So we're going to look at all the hemodynamic parameters.
Okay.
Both in healthy patient and preeclamptic patient. And we're just going to collect data. So we're going to have a large number of patients, because a lot of the studies so far have small sample size. So we want to be able to have a bigger sample size so people can use it as a reference for their studies.
Mm-hmm.
So that's one. And the other one, we are looking at the phenylephrine infusion rate, incidence of hypotension. So we are basically using crystalloid, colloid, and we're looking at the impact of using colloid, but with the help of the Clearside.
Yeah, fantastic. Well, that is phenomenal work. Congratulations.
Thank you. I'll be happy when it's done.
Good luck, I guess I should say at this point. I know.
Yes, for sure. Yeah.
Monty, anything else you want to come?
No, thank you for being a great partner.
Thank you.
Because, one of the reasons I joined Edwards Life Sciences, like many of my clinical colleagues, is because they're going down this path.
Yeah.
of trying to make robust, reliable, continuous.
But I have to say, all those studies, I started them before I actually joined you. I don't feel bias when I do those studies because I really started them way before. I really saw the interest of it way before that. So when Edwards approached me and asked me, can you be a consultant? I said, absolutely, because I really feel, I really believe in the device and I really see the advantage of it. So I have no problem doing that.
Yeah.
I think it's the same for all of my clinical colleagues at Edwards, that we did it for that reason.
Yeah, exactly.
So
yeah, see the benefit. Same.
Enough already for the guy from Edwards.
I know, right? God, Monty, you're killing. Well, Barbara, thank you so much for joining us here on TopMedTalk. I hope that we can catch back up after you have some of your data and I hope you guys are looking at that. We can hear about the results there. But good luck in all your journey with your colleagues.
Thank you for having me.
Yeah, absolutely. And thank you for listening to TopMedTalk. You can always find us at TopMedTalk.com. We're all over social media, Twitter, LinkedIn, Facebook. We are there. And YouTube. I know, Monty, we keep banging on about that this year, but this is new territory for us. So if you come across one of our videos, even the audio on YouTube, be sure to give us a thumbs up, subscribe to our channel. Every little bit helps, again, keeping TopMedTalk free and open access to the world. So thank you again to our sponsors. Thank you so much for listening. Cheers, everybody. And thanks to SOAP. We're going to hear more this weekend. Cheers.
TopMedTalk.
Thanks for downloading TopMedTalk. Don't forget to subscribe. Check us out on YouTube and, of course, on social media. We're on Instagram, Facebook and X. Also, it's important to remember that TopMedTalk is the broadcasting arm of EBPOM, evidence-based perioperative medicine. We'd love you to find out more about that, and the way to do that is ebpom.org. Check out our website and find out about some of the incredible conferences we're going to be arranging across the year. ebpom.org.